Good morning, and welcome to the second installment of the Tulane Innovation Series. This morning's conversation will focus on Tulane's leading role in the race for COVID-19 treatments, tests, and a vaccine. Since our founding in 1834, Tulane has specialized in combating infectious diseases. Back in the early 19th century, it was yellow fever and other tropical diseases that menaced our regions and coastal areas throughout the world. Today, infectious threats such as Ebola, Lassa, HIV, and of course COVID-19 are the focus of our research. The COVID-19 crisis is dominating the news cycle, disrupting our economy, and underscoring for all of us the importance of interdisciplinary research in addressing the most pressing issues. That progress in the fight against COVID-19. We'll hear from Robert Garry, professor of microbiology and immunology at Tulane University School of Medicine, and from Skip Bohm, associate director and chief veterinary medical officer at Tulane National Primate Research Center. Dr. Garry has gained national and international acclaim for helping to reveal the origins and evolution of COVID-19. He's also a veteran in fighting disease worldwide. Dr. Skip Bohm is part of the team at the Tulane National Primate Research Center that has mounted one of the country's leading COVID-19 responses. Today's discussion will be moderated by Kimberly Foster, Dean of Tulane School of Science and Engineering and Professor of Physics and Engineering Physics. Dr. Foster is passionate about interdisciplinary research and education. The work of faculty in her school often intersects with that of both the School of Medicine and the National Primate Research Center. In other words, she helps bringing the best minds from a wide array of fields together to address the greatest problems that we face in our society. That is what is going to take to defeat COVID-19, and that is what will also make this morning's discussion so fascinating. I am thrilled to have three of the country's top researchers from different fields together in one virtual room for what promises to be an extraordinary and enlightening discussion. Dr. Foster, the screen is yours.
Thank you, President Fitz, for your kind introductions. As President Fitz mentioned, I'm Kimberly Foster, and I'm Dean of the School of Science and Engineering here at Tulane. Let me join our president in welcoming you all here today. I'm honored to be here with two esteemed Tulane colleagues who are global experts in infectious disease to discuss the impacts of COVID-19 and the outcomes the state of the art in research is telling us. There will be time to take your questions later in the show, so let's get right to it. Bob, when it comes to answers about how exactly COVID-19 started, you are one of the leading authorities. Your recent article in Nature Medicine regarding the origins of SARS-CoV-2, or coronavirus, has generated a lot of excitement. You've been talking to reporters across the globe about your study, looking at the genome of the coronavirus to see how this spread from one animal to another and then to people. How did you determine where COVID-19 began?
Well, first let me say that SARS-CoV-2 is a natural virus. This virus came to us from nature. Nobody put this together in the laboratory anywhere. The way we determined that was to actually put together a team of scientists, and I think that's going to be a general theme running through today's presentation. We put a team together of the leading evolutionary virologists in the world, to people that have spent their careers looking at how viruses have evolved from one species and jumped into other species like into humans, unfortunately. So we took all that was known about coronaviruses, this family of viruses that have actually caused three pretty serious zoonoses over the past several decades, and looked what we knew about those viruses, compared the genomes of the viruses of those other coronaviruses to the new virus, the SARS-CoV-2. and looked at particular regions of the genome, compared it to the genomes of animal coronaviruses. And after doing all that work, it was very clear to us that this was a virus that had evolved through a natural process, had come from one or maybe even a couple of animals recombined and then entered the human population.
Thank you, Bob. That is really fascinating. Gaining understanding on the origins as well as how the virus can jump species may help in the prevention of future such events. One important piece in gaining this understanding is the research taking place at the Tulane National Primate Research Center. Now, Skip, there are likely many watching today who don't even know what the National Primate Research Center is and the important role that it plays in fighting infectious disease. Can you tell us a little bit about that and how its work is so relevant to COVID-19?
Sure. The Tulane National Primate Research Center is one of a network of 7 National Primate Research Centers located around the country. And the program is funded through the National Institutes of Health. And the overall mission of the Primate Center program is to improve human health through research using non-human primates. And at the Tulane Center, we were dedicated in the early 60s, 1963. And since that time, have focused our research program on infectious diseases. Some of the most notable research programs were in HIV/AIDS, malaria, TB, Lyme disease, recently Zika virus. And we also do a lot of research in diseases that are maybe not as well known to the public, but just as important to human health, like respiratory syncytial virus and cytomegalovirus. In addition to the 40 scientists we have on staff here at the center, we collaborate across the United States with approximately 200 scientists and help them accomplish their research goals that they can't accomplish at their own institutions because they don't have the expertise or the facilities to do those research studies. And so this very long history of a focus in infectious diseases, as well as our highly collaborative program, makes us well suited in this battle of the coronavirus to develop treatments and vaccines.
Wow, thanks, Skip. That is so interesting. And it is really wonderful that this resource exists to help speed up our understanding and race for a vaccine or a cure to COVID-19. Would you please share with us what you're currently learning so far about the COVID-19 infection and why the non-human primate model is critical in learning more about how to fight this disease?
Sure, I'll start with the model question. Right now there are several animal models that are being developed to study this disease, including the genetically modified mouse, the Syrian hamster, and the ferret, and of course the non-human primate. And models other than the non-human primate, like the rodent models and the ferret models, will contribute significantly to our understanding of the disease. But the non-human primate model has some distinct advantages when compared to non-primate models, and that is their genetic relatedness to man. Rhesus monkeys, for example, share about 93% of the genes that humans do, which makes them very similar to us in physiology, or the way our organ systems interact and our body works, and anatomy. And those are two important aspects of studying any disease. In addition, we know a lot about the immune system in non-human primates, especially rhesus macaques. We learned that in our HIV/AIDS program. And so when we're developing vaccines, that's really a critical component to understand moving forward. In addition, non-human primates are long-lived compared to those other species. And so questions that are arising now for those individuals that have recovered from coronavirus are, what are the long-term sequelae, or the long-term outcomes? What are the things that we need to be looking for in the long term? And the non-human primates are going to be very good models to study that. So in moving on to the next part of the question, which is, what have we learned? So up to this point, we've been spending a lot of time developing this model in non-human primates. And when I talk about a model or a disease model, what I mean is to show that an animal mimics or recapitulates the disease that we see in people, because it has to be similar or the same as disease in people in order to make them viable to test treatments and vaccines. And so what we know at this point in our early experiments is that we can indeed infect animals after exposure to the virus, and that they do have some of the same signs and symptoms that humans do. And this may have been a foregone conclusion of some, but there are some species of animals that actually can't be infected with the virus. So this was an important first step to show that after exposure, that animals become infected. And we use two types of exposure, one which mimics the contact, the mucous membrane exposure, and that is, say, somebody touches a tabletop and then touches their face, which we've all been told not to do. So we expose some animals to the virus using that technique. And then also an aerosol exposure, which is similar to when somebody coughs or they talk and you're standing proximal to them and you inhale the virus. And so both those routes of exposure worked and the animals were infected. Another finding was that the animals actually shed virus, similarly to humans, in high amounts from the pharynx, which is the throat, and also the nasal cavity. So that was another finding. And that this shedding occurred, our data up to this point goes out 2 weeks, and we're going to look at longer time points, but the animals shed virus and lots of virus for up to 2 weeks after infection. We also saw, similar to humans, that most of the animals didn't become overtly ill. They didn't have serious disease, and that is the same as in the human cases of coronavirus infection. But there was a subset of animals that did have serious disease that was similar to humans that are admitted to the hospital and put on ventilators. And so having both these ranges of disease are going to be really important to us moving along, especially to test treatments and vaccines. And finally, one new piece of data that came up was that in those animals with severe disease, we found that that the disease was probably, at this point, we're hypothesizing that it was caused by an overreaction of their immune system. And that has been hypothesized in humans as well. So rather than a direct cause of the infection of the virus, it's the body's attempt to fight the virus in an exuberant way that might cause some of these serious disease symptoms. So all these data are fairly preliminary, and we're still analyzing the data. But they are promising that the non-human primate is going to be an excellent model for studying this disease.
Thank you, Skip. Tulane is really fortunate to have such an amazing team of scientists, doctors, and veterinarians, all focused on uncovering the science surrounding COVID-19. On a related note, Sharon Courtney, Vice President for Government Affairs at Tulane, has a question that I think many around the world are also pondering. Sharon? Is Sharon here? Unmuted? All right. Well, while we're waiting to see if Sharon can be unmuted, I see that VJ John has an interesting question about the new vaccine the new vaccine work that was announced today in an article in the New York Times. VJ, would you like to ask your question?
Just would love to hear your opinions, the experts' opinions about this vaccine. That's all. It's a general question.
Skip, you want to take this?
Sure. So there were a couple of vaccines that have made the news recently. One that's called the Oxford vaccine and also the Moderna vaccine, both of which we've heard a little bit in the press about up to this point. And both vaccines seem to be very promising. The Oxford vaccine was just recently tested in rhesus monkeys, the model that I was talking about earlier, and shown to be protective. In that, the response to the vaccine in that case seems to be not a sterilizing immunity, but protection from disease, which means the animals were still infected for a very short period of time, and their own immune systems kicked in to eliminate the virus in order to prevent disease. And the Moderna vaccine is a nucleic acid vaccine, which means pieces of the genetic material from the virus are injected into the body or administered and cause the body to make pieces of the virus that are not infectious, that the immune system recognizes, so that when you have an infection, it could control it. So both of those vaccines seem promising. They're from different different platforms, different directions, and I think overall, what those articles in the latest information on these vaccines show is that a vaccine development is promising. And on a personal side, I'm optimistic that we will be able to develop a vaccine. It seems that in talking with some of our other colleagues who have not published their findings yet, that they're finding similar outcomes with even different platforms of vaccines. And actually, there are over 100 vaccines that have been said to be in the pipeline now, and I think that's probably an underestimate. I think there are a lot of vaccines that are being put together by big pharma, and we're not all aware of those yet. But there are lots of vaccines that are in the pipeline. So even if these early attempts fail, there'll be lots of vaccines to back that up. And I think that certainly we will be able to find a safe and effective vaccine. And so the safety part is of course critical to all of us, and we test that using our animal models.
Thank you, Skip. I have a follow-on. Bob, do you want to comment?
Yeah, I would just add that, I think we need to be pulling out all the stops to get these vaccines manufactured. So yes, there are a lot of different candidates there, but we should be ramping up now to figure out how we can get as many doses of the most promising vaccines made as possible. And I do think that there are attempts at this being made and strategies being laid out there and resources being deployed to get us to a point where, once we do identify the best vaccines, that they can be scaled and given to as many people as possible.
The chat window is going crazy with follow-on questions on the vaccine. A couple of them that have come up a couple of times. Some folks watching want to understand the difference between a vaccine and a therapeutic, and they also want to understand whether this is a live vaccine or not. Do any of you know about some of the candidate vaccines and could describe them in a little more detail?
So the two candidate vaccines that I just described are not live. They're pieces of the virus, and so they're non-infectious. There are some vaccines that are being developed that are whole virus vaccines, but the virus has been inactivated, which means there are several different methods that can be used to kill viruses to be administered. And several vaccines historically have taken that approach, but the vaccines we talked about today are not live virus. They're not even inactivated virus. They're pieces of the genetic sequence of virus. And
I mean, there are some differences between the approaches that are being taken too. So, typically you will try a lot of different ways to make the immune system, triggered to give a protective response. So, different vaccines work in different ways. Sometimes you stimulate one arm of the immune system, sometimes some of the other arms. And, we need to find out what is the best way to make a vaccine against SARS-CoV-2. I see one of the chat questions about, is there anything particularly challenging about a coronavirus that might make it hard to develop a vaccine? And I would say that I share Skip's sort of enthusiasm that we're going to get to a vaccine. I'm not seeing anything from the genetics of this virus that makes it look like, say, a virus like HIV, the virus that causes AIDS. The virus is changing. It's accumulating what we call substitutions. You might think about those as mutations, but not at an extreme rate and not at any rate that should be of concern to anybody. So I think that when we get a vaccine that it will be effective against pretty much all the lineages or isolates of the virus are out there. So I don't see any particular challenge that's going to keep us from getting to what is a very important goal.
Thanks, Bob and Skip. I think it's clear from the chat and from reading the newspaper every day that the race to a vaccine is first and foremost in many people's minds. At Tulane, we're very worried about that and interested as well, because we have to protect our students and our faculty and our staff and make sure that it's safe for people to be on campus. And a vaccine would go a long way to making us all feel safer, I think. I believe that Sharon is on now and has a question that I think is also relevant to lots of us.
Can you hear me now?
Yes.
Great. Dr. Garry, one of your research projects is tracking the viral strains of samples found in New Orleans to other samples to see exactly how this outbreak began. Can you tell us a little bit about what you're seeing in that study?
Sure. I mean, we have actually a large team here at Tulane, people that have been collecting these samples for the genetic analysis. And I've been working with some of my other partners that are experts in doing this kind of analysis of the viral genomes and actually just generating the sequences. And what we found with the viruses, the SARS-CoV-2 viruses from New Orleans is actually pretty interesting. We actually found that the genetic variability between the viruses is not that great. I mean, there are at most a couple of different lineages of the virus here in New Orleans, and they all seem to be related pretty much to each other. And what that means is actually important for some of the things that are important to our culture here in New Orleans. There was a lot of talk from a lot of different quarters early on that, you know, Mardi Gras was an event that may have caused the virus to have such an impact in New Orleans. And, you know, while we can't, you know, rule things out at this point in time, it certainly doesn't look like there were a lot of introductions of SARS-CoV-2 into New Orleans because of that Mardi Gras event. I mean, as I said, many of the viruses, all the viruses pretty much look like they are similar here in New Orleans, which is actually different than the situation in other countries. So if you look like at a place like New York City or San Francisco or Washington, where they have had a lot of cases too, their viruses are very divergent. I mean, there are a lot of different lineages, a lot of different you know, variants of the SARS-CoV-2 in those other cities. But here in New Orleans, it looks like there weren't that many introductions. I mean, there could have been some, you know, events that caused a great spread of the virus in the city, but I think that's mostly due to our culture and the way that people interact in our city. I wouldn't blame this on Mardi Gras. Other people have thought about, you know, well, Mardi Gras, other people came in here and brought the coronavirus back to other states or even other countries around the world. And so there have been people who said, well, Mardi Gras is what caused the virus to spread around the country. And actually, when you look at the genetics of the virus, that is not the case. I mean, the viruses in New Orleans have pretty much kept in New Orleans. There, you know, are a few of these particular variants that have shown up in a few other parts of the state. But if you look at the viruses in Louisiana and then compare them to the viruses that are in other states, you can make a pretty definitive statement that says, no, it wasn't New Orleans, it wasn't Mardi Gras that spread this virus around the country. It pretty much stayed in our own local borders.
Wow, Bob, that's fascinating. I'm so glad to hear that Mardi Gras is not the culprit. So along those same lines, I think Mac Hyman is on the call, and Mac is one of my colleagues in the School of Science and Engineering, and Mac is an expert in modeling the spread of infectious disease. So I think we have a question from Mac or comment.
Yeah, so my comment was that in Wuhan, 5 to 10% of the recovered patients tested positive again. And then on the Roosevelt, 13 of the sailors, after testing for several weeks with multiple tests of being virus-free, again were reinfected. And I'm just wondering how these cases, do they give you concern about the efficacy of future vaccines? even though the virus itself is mutating very slowly, something else must be going on. I just would like to have your feedback on that.
Yeah, I think, Mac, you're right that we're all concerned about reinfection, and that would occur after disease or after vaccination, and how long immunity happens after natural infection, how long that lasts. And this is just a snapshot of a few of the questions that have yet to be answered. And so there are lots and lots of questions. I think a scientist I read today was quoted as saying, we've really only been in research against coronavirus or looking at the viral infections for 17 weeks. So it's a very short time, and typically in science, an extraordinarily short time. We've made a lot of progress in that time. But these are some of the answers, as I said, that we'll be looking at in non-human primate models, and as well as the human population. But animal models offer us the ability to know exactly when an animal was exposed and to follow that animal out from day one, because there may be early responses, immune responses that are indicative or indicate what's going to happen in the long term. And those are things that we just can't do in people because we don't know when become infected and we're not following their immune response early on. So I think there may be some early indicators of prolonged shedding. As I said, in all of our animals, we know that they shed for 2 weeks, and that's something you're not going to see in humans at this point, testing as it is, but it may improve over time. But we can test animals on a regular basis every other day if necessary to follow those out. And we're going to have to do long-term studies to look at these different outcomes. And for vaccine studies, that's going to be a secondary part of the study, is to see, well, how long does immunity last? Can you protect them with one challenge? Yes, but that's only the start of it.
Thank you, Skip. Do you have a comment, Bob?
Well, I mean, it's an important question. I mean, we know that there are other coronaviruses that infect humans, and some of these coronaviruses cause, seasonal colds, and not the severe diseases that SARS-CoV-2 does, or, its relatives, the first SARS coronavirus or the Middle Eastern respiratory syndrome virus either. So, there are coronaviruses that cause much milder disease. And we know in those cases that immunity tends to be somewhat short-lived. But it's usually a year, it's usually a couple years. I mean, that seems to be the case in people. So it would be very unusual if this virus has found a mechanism to really either not induce protective immunity, at least on the short term, or that it would be possible to be reinfected with the same virus in a short period of time, like a couple of months. So we'll be looking at those studies that were mentioned very closely to see if those turn out to be something that happens again in other populations or other groups. But as Dr. Bohm said, I mean, there's still a lot to learn about this virus, and we need to figure out how to get good protective and, I would say, long-lasting immunity to it.
So I have a follow-up to that. What does that mean for the antibody testing? I know there's been a lot of controversy around the different antibody tests and their false positives and or false negatives. And since we don't know a lot about immunity, how should we view immunity testing as an important piece of this fight against coronavirus?
Well, it is going to be an important piece of the whole public health strategy. We need to have good serological test, antibody test, to figure out how many people have been infected. And, the assumption is that, those people will at least have some degree of immunity. Maybe that won't be what we call sterilizing immunity. Maybe that, it's possible that people can get affected again. But what we do hope that immunity will do is to give them some level of protection against serious disease. Now, when this pandemic started, I think that there was a decision made to allow a lot of the tests to come onto the market. And the FDA thought about that decision and evaluated some of the tests and said, well, some of these tests are not really that reliable. They're not that good. So we're going to walk back some of the, the regulations and make it a little harder, a little higher bar to get some of these tests, the antibody test, on the market. And so I think as we go forward, we'll be able to put a lot more faith in the results of those tests. I mean, we ourselves took a little bit more of a slow approach. We know we didn't want to rush out there with a test that hadn't been fully vetted and fully tested in our hands. So in our group, we've actually made some antibody tests, and there's some other antibody test. My colleague James Robinson, who would have also been good to come on here, one of these kind of forums, because he's a wealth of information about the human immune system and antibodies and the like. And he's developed some very good tests too. So I think we will be able to put greater faith in these tests going forward. Serological tests are going to be important in how we get back to work here.
Thanks, Bob. Along that same note, Skip, what is the timeline for moving vaccine testing from primates to humans? I think everyone is concerned about timeline, and I've certainly have seen a lot of chat about how long it will take before these vaccines may be reliable and available.
Yeah, I think of all the questions I've been asked in interviews, that is the most common. What is the timeline? And you hear it in the media all the time. And I would answer truthfully that it depends. But because there are a lot of variables to development of a vaccine. And as I said earlier, the early animal model experiments, which we did, are a prerequisite to testing any vaccine. And those experiments themselves can last months or a year or more than that. We're at a point now where we're close, I think, to start. We'll be vaccinating some animals in the next couple of weeks for challenge experiments to evaluate yet another vaccine. But even after doing the experiments, so just to kind of break it down a little bit into the timeline, we developed the animal model first, and that can take months or a year. Then once you've got an animal model validated, then you can start testing animals for vaccines. And so while you're validating the animal models, scientists are putting vaccines together to test. So that runs in parallel, and that's that saves a little time. But then you have to do the trial in animals, which is to vaccinate animals for a period of time, and then expose them to the virus, and then follow them just like we did in the model study, where we're taking samples over a period of time and analyzing those samples and tissue samples, and then you've got a lot of data, and you have to analyze those data because you want to make sure that the conclusions you're drawing about a vaccine are true. And so that takes time. And as we can see with science and coronavirus, it's moving very quickly, and there are a lot of preprints, which means scientists haven't evaluated those. They haven't been peer reviewed yet. And so there's a lot of news coming out, but science is moving very quickly, I'd say, in this, at greater than any vaccine development in history. And I imagine that's going to happen very quickly. But still, after the animal experiments, then we have to do human trials, and there are several phases there. And some of those phases are highly dependent on the infection rate in the community. So if the infection rate of the virus is going down, which is what we all want, it takes longer to do some of these trials to prove that the group that was vaccinated has less infection than those that weren't. And so that also plays into the timeline. But as I said, I think the rate with which we're making progress now is faster than has ever been seen in history. I think the fastest vaccine development was 4 years in Ebola, and I think we're gonna do better than that by a long shot. But will we have a vaccine by the end of the year? It's highly unlikely that we'll have a vaccine by the end of the year. But in 2021, perhaps, if some of the first vaccines that are being tested make it there. So again, the long answer or the short answer is it depends. But I'm optimistic not only about our ability to create a vaccine, but also with the speed that we'll have to create it. One last point I want to make before we move on is that we have to make sure in all of these tests that the vaccine is safe, obviously. So we want to make sure that antibody-mediated enhancement doesn't happen. The disease is worse after receiving the vaccine than if you hadn't received the vaccine. And we will certainly assure that the vaccine is safe by testing the animals and all those phases of human trials. That's what they're designed to do. So we can't rush those. They have to be done because, of course, we want a very safe and effective product to go into the human population.
That's really, really helpful, Skip. Thank you so much. I'm enthusiastic about the development of a vaccine. Along the Mardi Gras and New Orleans line, we have an interesting question from James Holmes, which asks about whether the Mardi Gras results suggest that social distancing in outdoor settings may be significantly less important than indoor, that outdoor environments are low risk of infection. Can either of you comment on that?
I mean, I'll comment on that, although I will take some data from one of Dr. Bohm's Tulane Primate Center colleagues, Chad Roy, who has shown us that this virus is able to aerosolize and to stay in aerosol suspensions for a considerable period of time and to remain infectious in those aerosols. So I think it is important to remember that this is a respiratory virus. And the major way that this virus is spread is when we get into other people's space, when they're breathing or talking, or, we've even seen singing be a very significant risk for spreading the virus. There was a choir where a lot of the choir members became infected just from a single person. So we know that just normally what I'm doing now, talking and to a lesser extent breathing, creates these small particles. I think there's been a little bit too much emphasis in the news media about, is it a droplet or is it an aerosol particle or all that. I mean, this is in the bottom line a respiratory virus that most of the infections are going to be when you get into somebody else's space. So that's why social distancing is important. I mean, yes, it is possible to spread it from touching a surface that has the virus on it and then putting up your hands or your eyes into your nose, mouth, or even your eyes. But for the most part, we get this by being in somebody else's space. So was Mardi Gras a good way to spread the virus? Probably not as much as, maybe sitting in the restaurants or, being in close proximity to people, but being out the parades in the open air, that's not the best way to spread the virus. It is one of the things that we need to be keeping in mind as we go forward with the reopening of the schools, and we all hope that we can do that, and of businesses and things like that. I mean, wearing masks is an important way to stop the spread of this virus. And so if you're of the mind that I don't really want to put a mask on because it's uncomfortable, I would just urge you to think about the fact that, it's the mask that keeps this virus from spreading to other people. No, the mask is not going to be a great way to actually protect yourself very well from the virus because, as I just mentioned, it is aerosol. So you can still breathe in through that mask. But what the mask does is it keeps your droplets, the big ones and the small ones, from going very far. So you can actually make a pretty big impact. If you happen to be, one of those asymptomatic people or somebody that has just a mild symptoms of spreading that virus to somebody else. And that's what we really need to be mindful of protecting, particularly our most vulnerable people in the population, those that are over 70 years old or have some underlying conditions like obesity or hypertension or diabetes, because those are the people that have the bad outcomes. So wear that mask. Don't spread those droplets around, and and protect our fellow citizens.
Thanks, Bob. I think this is really guiding us at Tulane as we think about how to move forward and how to protect our faculty, staff, and students. There's been a number of questions in the chat about coming back to campus and whether it's safe to go to sporting events and things of the like. And I think these things that Bob has just mentioned are really going to be critical in making those decisions. At Tulane, we are doing so much scenario planning. Like was mentioned earlier, we've only been doing this for 17 weeks and the virus is new, and scientists are scrambling to learn more and more about it. And so it would be great, I think, if we had all of the information now and we could make decisions, but we don't. And that information is changing by the day. So I think at Tulane, I'm really proud of all the hard work that we're doing to try and make sure that we protect our faculty, our staff, our students, and our community. I think it's really essential, and right now it takes a lot more work. It takes a lot more effort to plan for 3 or 4 different scenarios, but we have no choice at this point because we need to be able to make decisions that are based upon data and scientific evidence, and that evidence is still coming in. So I think this is really good news that there are some promising vaccine candidates. It's also good news about the antibody testing, and the more that we understand about and can develop valid tests and possible vaccine and treatments, that'll be really interesting. There's a couple of interesting things that I'd love to touch on based on the chat. One was someone asking about other therapeutics. Beyond vaccines, treatments for the virus. Do either of you know about the potential of other treatments for people who have the virus when they're fighting it?
So I can just comment generally, and Dr. Garry will certainly want to comment as well. But obviously, there is a percentage of the population, as Dr. Garry said, that are predisposed to severe disease, and so we have to address that issue that's occurring in the pandemic. And so the most rapid way to facilitate development or testing of antivirals or other drugs that can be used to minimize this negative outcome is to use those drugs that are already being produced and already as antivirals. And the reason we can expedite those is because the testing has occurred, so safety testing has occurred. So what needs to be done in that case is efficacy testing. We need to know whether they actually work or not. And the important part about that is that we have to have a model to do that. So we a model of severe disease that we can test that in, but because they are also already approved for use in humans, sometimes those therapies can be expedited, the testing in actual patients. And so those are, I think, in my mind, just the general principles that we will need to pursue treatments as well as vaccines. And you hear a lot about vaccines and not as much about treatments, but they're going to serve an important role as much as vaccines in the need for development.
So, I agree that, that the vaccines are going to be critical for getting us, to the next phase of this pandemic, and treatments too, for hopefully mitigating some of the people that, would develop a fatal disease or very serious outcomes from it. Those kinds of treatments, we need to find those good drugs that will, to shorten the course of the illness or to make it less severe. But I'm going to go back to sort of a lesson I learned during the Ebola outbreak. There was, as most people on this webinar will know, a large outbreak of Ebola from 2013 to 2016. And at that time, there were no good Ebola vaccines and no good therapies for Ebola. But nevertheless, the outbreak was brought under control. So there are a couple reasons why that happened. First of all, there were interventions. So there was contact tracing and there was testing. That's very important. We need to get those public health devices in order and get enough tests and get public health people to be able to do contact tracing. But the most important lesson I learned about the Ebola outbreak, it was that it was ultimately the people that were being infected, the people in West Africa that took it into their own hands and in their communities and in their households that really made the difference. I mean, you know, the contract tracers are great, the testing is good, but it's the same lesson we can learn here. People, to get this COVID-19 outbreak under control, are going to have to take it into their own hands. So as we all go back to work, and everybody wants that, one of the things we have to keep in mind is that if you're just the slightest bit suspicious that you might have a COVID-19 infection, you know, don't tough it out. Don't go in like we all used to do when we had a cold or some, you know, a fever or symptoms like that, going to work. You've got to stay home, you know, and because it's, you know, even if there's just the slightest chance that you might have this virus, then stay home. Don't infect other people. If you do get sick, then please, you know, notify, you know, as we get this contact tracing into order, notify people that you are a case. And they will try to find your contacts and notify them and try to get them into some sort of a, you know, a sheltered position where they don't spread the disease on. And if we do actually take those measures and are, you know, as a community, as a society, we will be able to get this under control.
Thank you. Let me second that. I really think that we do need to destigmatize staying home when you're sick and keep everyone safe. Tulane's motto is the translation from Latin is not for oneself, but for one's own. And I really think that we all need to have that in mind as we try to protect our community against further spread of COVID-19. In some interesting questions coming from the audience about reopening and the effects of and testing, and that applies to both Tulane as well as local businesses and how do we think about reopening? So David Dubin has a question. David, would you like to ask your question? You can unmute.
Hopefully you can hear me now.
Yes.
Excellent. And a Tulane alumni. Question would be if, you know, whether it's businesses, universities, schools, if you were looking to, you know, screen staff on an ongoing basis as routine maintenance, if you will, approximately how much of an interval would you do for the team on an ongoing basis? You know, would it be twice a week, once a month? Any thoughts on that?
That's a really good question. I think a lot of people are grappling with that. And certainly the type of testing that you're doing applies in that antibody testing, again, putting certain assumptions aside, if we test for antibody which indicates previous exposure and potentially resolution of infection, we're looking for antibody. Obviously, that is done infrequently and maybe only once to prove that somebody has mounted an immune response. Now, the question is as it came up from previous callers, that can you be shedding virus and still have a antibody response? We don't know entirely whether that can happen. But if that happens, that really complicates a lot of things. But certainly if we're testing for virus, I know at some of the other universities where I have colleagues, they're testing some staff once a week, high-risk contact staff that get in contact with animals or patients, their healthcare staff, once a week and doing PCR. So they're detecting virus in those individuals or trying to detect virus. And so that's, that's pretty intensive. And, it comes between trying to figure out, and you can do a risk analysis with, if we test once a week versus once every 2 weeks versus once every 3 weeks, what's the risk? And a lot of that depends on the infection rate in the community, risk factors, and all of those things. So it's really not a simple question. And I think, I don't know the answer to it. I just know what others are doing. And once a week testing for virus is in place, but it is quite a hardship for those individuals at those institutions that are having nasal swabs once a week. I can tell you that they're not happy about that. And we don't really, again, know what the real risk is if we stretch that out to every 2 weeks. But certainly when you're detecting the virus, it's day to day. You can be shedding virus one day, and the previous day you may not be shedding virus. So it's certainly with viral detection, you've got to kind of hit the nail on the head. Whereas antibody detection can be that'll be our assessment of herd immunity or people that have been previously exposed. And if they do have immunity, then you can have some some assurance with antibody testing that that person is protected. But again, none of this has been validated at this point.
And I guess I would add that the rate of testing or how often you test is going to vary from population to population. So, for example, we may want to test the members of our Tulane football team who are going to probably go out on the field, we hope, and compete. Not sure if there'll be people in the stands or not, but compete with other teams. We may want to test those individuals more frequently, at least once a week, and probably more than that, maybe at least twice a week, probably, before they go and after they come back from the games. But other populations may not need to be treated or may not need to be tested that often. It will depend on the various circumstances. And the other point I would make is that the testing is just one part of the mitigation that we're going to do, the prevention that we're going to take. So things like social distancing, everybody wearing a mask, keeping meetings to small groups, less than 10 people, all those things. And again, just, making sure that a person doesn't come into work when they have a fever or some other symptom. Those kind of things, along with the testing, are going to keep our communities safe here, the Tulane community and the broader community.
Yeah, and I think I just want to emphasize that, and we've emphasized it a number of times. What Dr. Garry just said, it's not just testing, it's everything else that goes along with testing. It's a whole program of preventative health, and that is people have to be responsible for themselves and taking precautions, not coming in when they're sick, not congregating. And so those are important adjuncts to testing. I think everybody wants to hang their hat on just testing, but we want to prevent infection.
Thank you both. I think this is just so important to understand that we're still learning about this every day. And so as we learn more, we can do a better job of protecting and preventing, but in the meantime, we just have to trust the science, and we're so happy to learn from both of you. We've learned so much today. As a Dean of Science and Engineering, I follow the federal funding climate, and it's been great to see all of the federal agencies, the National Institute of Health, the National Science Foundation, and the Department of Defense devoting resources and having very quick grant proposals. This goes for private foundations as well. Everyone there's a lot of resources going to COVID-19 research, and I know that Tulane has been able to take advantage of a lot of that, and this is supporting some of the work going on in your labs, among others. But I really think that the putting the money into research and really waiting impatiently for the output is what the country is really after. So this is really interesting. I saw one interesting question coming in from someone from Bangladesh, and he was wondering why the virus was so bad in certain countries like the US and Spain and Italy, and why it has not been as devastating in his country and some others. Do you have any comments on that?
Well, there's been some talk that the virus might, have different strains, or, that may have mutated and become more virulent in some parts of the world than other parts of the world. I don't see any evidence for that yet. I mean, there are some mutations that seem to have taken hold, one particular one in the spike protein, but we just don't have enough information at this point to tell you that, yeah, the virus has changed in a way that has made it more transmissible or more more able to cause serious illness. No evidence for that whatsoever. And I, most people ask me that, and I just say, look, this is a virus that spreads very easily in people already. So if we're asking, is it very, very, very good at spreading, or is it very, 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 very good at spreading? I mean, there's really not that much difference in those two outcomes in terms of, what the virus is doing to us. Now, that having been said about the virus, I mean, there are differences in different countries, obviously. I mean, in the US, we have a lot of people that have these conditions that might make it more likely to have a serious outcome. And so things like obesity and hypertension and diabetes all contribute to risk factors for having a more serious outcome. So those factors do vary from country to country, and they're not going to be the same, and so we're going to have different outcomes, different levels of mortality, not just in different countries, but in different parts of the countries.
Thank you, Bob. I have to say, this is, I've learned so much today. There's been a lot of comments, and I wish we had more time to address them, but there have been a lot of comments about reopening Tulane, about bringing students back, about testing. I will say, someone asked a question regarding how you are all helping, how Skip and Bob and others are helping to inform Tulane administration on bringing folks back. And I will say that Tulane has a lot of committees that take these results and this knowledge extremely seriously as we try to plan for coming back. There will be, so testing and state-of-the-art protocols are being developed by the day. And like I said before, we're still scenario planning because we learn more every day. So if we had said what we were doing a month ago, we would probably have had to change our minds based on what we have learned in that time. So we are trying to be careful. Safety and health of people are extremely important to Tulane. And so Tulane has a lot of task force committees that are approaching every bit of this problem. And we want to ensure the safety of everyone. So the scientists and the material we're finding out every day is really informing us. And so as this progresses, we can make more and more definitive statements about what we will do in the fall. But for those of you who are waiting to see if you'll be coming back to Tulane in the fall and studying in person, I can tell you that we certainly hope that we can do that, but it will be in a very safe manner, and it will involve testing and screening and encouraging and making sure that we don't infect each other because a university is a large community of people. But I really want to thank you all for participating. I really want to thank Skip and Bob for all their expertise. This is just fascinating, and maybe we can do it again in a month when you know so much more. I know things are going at a crazy pace, but I really hope everyone has enjoyed and learned a lot. I know I've learned a lot, and I've really appreciated everything that was brought to the table today. So thanks to the audience for your great questions and chat. Thanks to the panelists, and thanks to President Fitz and the rest of the Tulane staff for putting on this Tulane Innovation Series. And I hope you tune in to a future episode. Thank you very much.
Appreciate the opportunity.
Me too. Thank you. Great job, Skip.